Trauma call comes in. You pull up, assess the scene, and somebody says, quick, grab the backboard. But here's the question. Are we helping the patient or just following outdated habits? Today on EMS MythBusters, we're digging into spinal immobilization myths and why backboarding every trauma patient might actually be doing more harm than good. Here's the myth. All trauma patients need to be fully immobilized on a long spine board regardless of symptoms. This idea has been drilled into EMS culture for years, but more and more evidence is showing us that routine backboarding isn't just unnecessary, it's potentially harmful. Back in the day, the mindset was better safe than sorry. Any trauma, especially if there was a mechanism of injury, meant full spinal immobilization with collar, board, and straps. But now, we know better. Studies show that long spine boards don't prevent movement, they can actually cause pressure ulcers, respiratory compromise, and increased pain. The current trend is towards spinal motion restriction, not immobilization. SMR means you only restrict the spine when clinically indicated and you do it in the least harmful way possible. That might mean a collar only, or allowing the patient to self-extricate and lay flat on the stretcher if they're stable. I've seen patients with no neck pain, fully alert, get strapped to a board for 30 minutes of misery. No spinal injury, just a sore back for a week because of how we treated them. Use your assessment. Is the patient alert, not intoxicated, no distracting injuries, and has no midline pain or tenderness? Then they likely don't need a backboard. So is backboarding still required for every trauma patient? No, it's about spinal motion restriction, not immobilization, and definitely not punishment. Want to learn how to do modern SMR correctly? Let me know in the comments, and I'll break it down in a future video. Like, subscribe, and remember, good medicine is evidence-based, not habit-based. I'll see you next time on EMS MythBusters.